I want to start out with saying that I do not get paid for the time that I devote to working for single payer. The time I spend is taken from my personal life and from my medical practice. I donate money and materials as well as time to this issue. And the reason I do that is that since entering the medical field, starting my first practice in 1982, I have watched the healthcare system fall apart around me. And I cannot practice as a physician unless I'm involved in working for single payer. I want to state, first of all, what I take to be the goals of any healthcare reform. I would say they are universal access to high-quality medical care, that is, access for everyone, protection for everyone against financial problems from medical bills. Those are the primary goals. And to achieve that, we need affordable health care because only by controlling costs can we achieve the goal of having universal access. We in the single-payer movement maintain that only a single-payer national health care system can accomplish these goals. And to show you why that we believe to be true, I'm going to address three different aspects of this. One is how these different plans, the single-payer plan and the HCAN plan, came into being. The next is the underlying ethical principles of these two plans, and finally, the evidence and logic behind the two plans as I see them. So beginning with how these plans came about, first of all, the single-payer plan has been in development for the past 20 years, since the founding in 1987 of Physicians for a National Health Program. In 2003, the physician's proposal for a national health program was published in the New England Journal of Medicine. Throughout the work for single payer, the plan has rested on meticulous analysis, meticulous research. This has been published in peer-reviewed journals, and all of the background and all of these papers are available on a website, pnhp.org, that is accessible to everyone. In contrast to that, how has the HCAN plan developed? It has developed behind closed doors, in secrecy, and it has involved the insurance industry, the very people we have agreed are at the root of the problem. The single-payer plan has been developed by physicians, physician scholars, practicing physicians, especially primary care physicians. They are not people with a conflict of interest in developing the legislation. So that is the contrasting way in which these two plans have developed. What are the underlying ethical principles of these two plans? The underlying ethics of the single-payer plan is social justice, social solidarity, everyone in, no one out, one nation, one plan, a single tier of medical care for every person in the country. That is our ethical principle. What is the underlying ethical principle of the HCAN plan? Social disassociation. People with health insurance who like it are separated from people who don't have health insurance or have health insurance that is of no use to them. We have still a program for the elderly, Medicare, a program for the very poor, Medicaid, different programs for other people. And I have to throw in here that actually I'm speculating here because we don't actually know what the HCAN plan is going to be because there isn't any legislation. The single-payer plan, by contrast, has a bill already in the legislature, H.R. 676. We have laid out what we are working for. HCAN has not done that. We do know that HCAN has had rallies around the country in which the insurance industry is attacked, and people are invited to tell horror stories about the insurance industry, and yet in the halls of Congress, it is the insurance industry that is given an honored place. And at the same time, those of us who advocate for single payer are specifically excluded from both the inside and the outside discussions of health care reform. That is another difference between how these two plans have developed. Now I want to turn to the evidence and logic behind these two kinds of plans. First of all, for the single-payer plan, we draw on the evidence of international experience, that countries that have single-payer plans have achieved universal coverage, and they've achieved it for much less cost than the United States. Half of what we spend in Canada still covers all of their people. In England, even a smaller percentage of what we spend covers all of their people. So this is the experience, the knowledge we have from the international community of what works. We also know from international experience that the more payers there are in any system, the more expensive that system is. So we know this from European countries where there are a variety of payment systems. The single-payer system is the cheapest. Addition of any more payers, even if they are tightly controlled, not-for-profit insurance companies, still means higher costs. There is no country that has anything like universal coverage that has for-profit insurance companies. There is no such thing. What experience do we have from our own country? We have multiple attempts in multiple states to try hybrid plans. Hybrid plans means a mix of public and private insurance, and we know that each of those has failed. Massachusetts has done it twice. Maine, Hawaii, Tennessee, Oregon have all tried this. In every case, universal coverage was not achieved. Costs increased. They did not decrease. Costs increased. There was not the delivery of high-quality care, and people remained at risk for homelessness and bankruptcy due to medical bills. So a mix of private and public has never succeeded. A single-payer system has succeeded in other countries. That's the first line of evidence. Then I want to look at what we know from a public program in our own country, specifically Medicare. Before we had Medicare, we had private insurance, and private insurance started out to be not-for-profits, the Blues. These were not-for-profit organizations that had community rating of health insurance. It was considered unethical. If you can believe this, it was considered unethical to charge different rates to different people depending on their pre-existing conditions. That changed when the commercial insurers got involved in health insurance and started selling their insurance products to people in specific groups, like the employed. So they cherry-picked the least expensive groups, offered them lower premiums. That meant that the least expensive patients migrated away from the Blues, from the not-for-profits, leaving the Blues with mounting expenses and the inability to compete in premiums with the commercial insurers. Inevitably, the Blues had to start offering the same products that the commercial insurers did. So this is the beginning of the history. Then we have Medicare, which is in a sense a private single-payer system for what it covers, but it does not cover 20% of all costs, a yearly deductible. So we have a secondary insurance, a supplemental insurance that takes care of that. You have to buy that from private insurers. Medicare's overhead costs are 3%. The overhead costs of the supplemental insurers are greater than 20%. That's the difference between what private insurance does and what Medicare does. But we don't stop there. We now have Medicare Advantage plans. The Medicare Advantage plans skim the healthiest patients. People who go into Medicare Advantage plans are healthier than the average Medicare patient, but the private insurance companies have gotten from Medicare 112 to 115% of the average cost of a Medicare patient. They select the healthy patients, treat them well when they're healthy. When they get sick, they have higher copays. They migrate again out of the Medicare Advantage plans back into regular Medicare where they cost more. This is how the insurance companies operate. And remember, they have now Medicare Part D, which has no public plan at all. So they've advanced from supplemental insurance to Medicare Advantage plans to Medicare Part D. And their next step is to get even more subsidies out of the taxpayer for their products. That is what we see as the step that they are aiming for. And they have the power to do that because they own the legislators who are writing the legislation for the public plan. So we say we can only have universal coverage, high-quality medical care, control of costs, and financial protection for people if we eliminate the private insurance industry.
10 minutes.